56% of medical students in a study published in the Proceedings of the National Academy of Sciences believed that black patients have thicker skin than white patients. 56%. These were people weeks away from becoming licensed physicians. And that belief, with zero biological basis, not supported by a single credible study, directly changed how much pain medication they were willing to recommend for black patients. That study was published in 2016, not 1950, 2016. That is the world I work in every day. And today I want to tell you something that most doctors either do not know or have never stopped to question. The medicine you were taught, the medicine still being taught in medical schools across this country, was built largely without your body in mind, not as an opinion, as a documented fact. And I want you to understand what that costs you specifically, in a clinical setting, the next time you walk through a hospital door. Let me walk you through this carefully, one piece at a time. Every medical student in this country learns from textbooks. They memorize normal ranges, normal kidney function, normal lung capacity, normal oxygen levels in the blood. These numbers are presented as universal, as if a body is a body and human biology works the same regardless of who you are. But here is what those textbooks do not say. The populations used to establish most of those normal ranges were overwhelmingly white. A study published in The Lancet in 2020 analyzed images across major medical textbooks and found that the vast majority of photographs used to teach disease recognition showed white or light skin as the baseline. Conditions that look dramatically different on darker skin were either missing or labeled as rare variations. Think carefully about what that means for a doctor examining you. They learn to recognize illness on white skin. When your skin presents a symptom differently, there is a real possibility they miss it entirely or misread it as something minor. But the problem goes much deeper than photographs. I want to talk about your lungs first. For decades, pulmonologists used a test called spirometry to measure how well your lungs work. They compared your results against a predicted normal value. Here is the problem. That predicted normal value was automatically adjusted downward for black patients. The assumption baked into the software was that black lungs naturally hold less air. This was called the race correction factor. It was built directly into the medical devices used in clinics across the country. When a black patient got tested, the machine applied a lower threshold before printing results. A black patient with genuinely reduced lung function could receive a reading that looked normal for their race. The disease was hidden behind the adjustment. That patient might not get treatment, might not get referred to a specialist, could spend years getting sicker while being told their numbers look fine. The American Thoracic Society updated its guidelines in 2022 and eliminated race-based spirometry equations. They acknowledged that using race as a biological variable in lung function testing was not scientifically valid. That guideline change matters, but guidelines do not reach every piece of equipment or every clinic overnight. If you have had a lung function test in the past several years, you have every right to ask your doctor whether race-based corrections were applied to your results. Now let me talk about your kidneys, because this one is serious. Kidney function is measured using a calculation called estimated glomerular filtration rate, which doctors shorten to eGFR. This number tells your doctor how well your kidneys are filtering your blood. It drives major medical decisions. When your eGFR drops below a certain level, you qualify for a specialist referral. When it drops further, you qualify for preparation for dialysis. When it falls further still, you qualify for evaluation for a kidney transplant. For years, the standard formula to calculate eGFR included a race correction. If you were identified as black, your calculated eGFR was boosted upward. The assumption was that black patients naturally carry more creatinine in their blood due to greater muscle mass, so the formula compensated for that. Here is what that actually did in practice. It made black patients appear to have better kidney function than they actually had. A black patient and a white patient with the exact same true kidney function would receive different numbers. The white patient's result might qualify them for early intervention. The black patient's artificially boosted result might not. A study published in the Journal of the American Society of Nephrology found that removing the race correction reclassified a significant number of black patients into more severe stages of chronic kidney disease. These were people who were sicker than their charts indicated. Some had been waiting longer for transplant evaluation. Some had been referred to specialists later than they should have been. The National Kidney Foundation and the American Society of Nephrology released new guidelines in 2021 recommending that race-based eGFR calculations be eliminated. The updated equation is called the Chronic Kidney Disease Epidemiology Collaboration 2021 equation, and it does not use race at all. But here is the reality. Guideline adoption is slow. If your doctor is still using the old formula, your kidneys could be sicker than your chart currently shows. That is not a small thing. That is your life. If you have ever been told your kidney function is in an acceptable range, ask your doctor specifically which eGFR equation was used. Write that question down before your next appointment. Ask whether it was the 2021 race-free equation. That is a completely reasonable medical question, and you have every right to ask it. Now I want to talk about something that could affect you in an emergency room right now, tonight. Pulse oximetry. That small clip they put on your finger to measure your oxygen level. You have seen it. You have probably had it on your finger in a hospital. Most people assume it reads oxygen directly like a blood draw. It does not. It uses light. It shines 2 wavelengths of light through your finger and measures how much light is absorbed to estimate how much oxygen is in your red blood cells. The problem is that melanin, the pigment that gives darker skin its color, interferes with that light signal. A study published in the New England Journal of Medicine in 2020 analyzed patients hospitalized with respiratory illness and found that Black patients were approximately 3 times more likely than white patients to have what is called occult hypoxemia. Occult hypoxemia means your true oxygen level is dangerously low while the pulse oximeter is displaying a reading that looks acceptable. The device is giving a false reassurance. In a routine hospital stay that might not cause immediate harm, but in a respiratory crisis, when a physician is deciding whether to start supplemental oxygen, whether to move you to intensive care, whether your lungs are failing, a falsely high reading can delay treatment that you urgently need. Researchers specifically raised this concern during the respiratory illness crisis of 2020 through 2022. The Food and Drug Administration has since issued a safety communication acknowledging that pulse oximeters are less accurate in patients with darker skin tones and calling for new device standards. But the devices currently in use at most hospitals have not been replaced. They still have this problem today. So what do you actually do with all of this? The first thing I want you to hold on to is this. None of what I have described today means you should avoid medical care. Please do not leave this video feeling like the system is so broken it is not worth engaging. That would cost you your life in a different way. What this means is that you need to be an active participant in your own care. There is a difference between going to an appointment and receiving whatever information you are given and going to an appointment prepared to ask questions and advocate for yourself. When a test is run on you, you are allowed to ask what reference range was used. You are allowed to ask whether a race-based correction was applied. You are allowed to ask what your result would be without that adjustment. These are legitimate medical questions. A physician who is current on the literature will welcome them. And if your questions are dismissed without explanation, that is important information about whether you are getting the quality of care you deserve. Second, if you have a chronic condition involving your kidneys, your lungs, or any condition where monitoring is part of your regular care, bring this information to your next visit. Tell your doctor you have learned that the eGFR race correction has been updated and ask whether your records reflect the new calculation. Tell your doctor you understand that pulse oximetry can give falsely high readings in darker skin and ask how your care team is accounting for that. These conversations can happen. You have the right to start them. Third, if you ever feel that your symptoms are being minimized, that your pain is being undertreated, that a reading is being accepted as normal while your body is telling you something is wrong, you have the right to ask for further testing. You have the right to request a second opinion. You have the right to bring a trusted person with you to your appointments to help you ask the right questions and remember what was said. I want to pause here for a moment and speak to you directly. If you have been watching this channel for any length of time, you know that my goal has never been to make you angry at individual doctors. Anger without a direction to move in does not heal anyone. My goal is to give you the kind of information that your 10-minute appointment rarely has time to include. I want to be the doctor who actually sits down, turns off the clock, and tells you the truth about what is happening in medical science and how it affects your body. If this video showed you something you did not know before, I want you to do one thing right now. Subscribe to this channel so you do not miss what comes next. And leave me a comment below telling me which part of today hit closest to home for you. Was it the lung testing adjustment, the kidney formula, the pulse oximeter reading, or that statistic about medical students that we started with? Tell me. Because when you share what landed, you help someone else in this community understand they have not been imagining what they felt in those exam rooms. You help someone else realize they are not alone. The research gaps I described today are being closed, slowly, by scientists and physicians who recognize that medicine built its standards on incomplete data and is working now to correct that. New equations, updated device standards, and revised guidelines are emerging. But you cannot afford to wait for the whole system to catch up before you start advocating for yourself. Your body is not a footnote. Your biology is not a variation from the norm. You are the norm. And it is long past time that medicine builds its standards like it understands that. This content is for educational purposes only. Please speak with your physician about anything discussed here. I am Dr. Marcus Webb, and I will see you in the next video.